Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I want to welcome you to today's webinar, which is going to be focused on COVID-19, both vaccine administration and vaccine education. Before I introduce our fabulous panel, which you see on your screen, let me just tell you a little bit about the PCC, go over some housekeeping, talk a little bit about how our conversation is going to go today, and then provide some introductions. The Primary Care Collaborative is a nonprofit organization that brings together over 60 different organizations to advocate for primary care as the foundation of a high-value health system. We focus not only on the patient-centered medical home, but other models of advanced primary care. Today's conversation will be about vaccine administration and education. As you know, we're about 2 months into the administration of vaccines, and we have seen different parts of the healthcare system leveraged to administer the vaccine. We're very interested in this next phase where primary care will be leveraged, and we'll be able to draw on all of the amazing assets that primary care can bring to the table to help our nation meet our vaccine goals. Let me just provide some housekeeping reminders. We've got hundreds of people on the line today, so all of your lines are muted, but you can ask questions through the chat feature, and we encourage you to do so. We're going to have a conversation for between 45 and 50 minutes and reserve the last 10 to 15 minutes for your questions. We also are recording this webinar, and it will be made available about 2 days after we conclude today's event. Now let me introduce our fantastic panelists. Let me start with Angelica Getter, who is the Chief Strategy Officer at the Black Women's Health Imperative. Angelica focuses on healthcare disparities and the impact of racism on Black women's health. She's recently joined the Black Women's Health Imperative, and prior to that, she was the first ever Chief Health Officer for Atlanta, where she focused on COVID-19 prevention, surveillance, and preparedness efforts under the mayor's office. You know, I think what Angelica brings is experience on the ground and also a focus on health equity. It's wonderful to have you, Angelica. Darylyn Moyer is Executive Vice President and CEO of the American College of Physicians and Chair of the PCC Board. She's board certified in internal medicine and infectious diseases. And prior to being at the helm of ACP, she was Executive Vice Chair for Education at Temple University. Darylyn also continues to practice at Temple and has background and experience in taking care of HIV patients, so very relevant to our discussion today. There's lots of analogies. David Fairchild is the medical officer at CVS Minute Clinic, and prior to that, he was director at BDC Advisors, which is a consulting firm. David has worked in a lot of different positions to really bring physician leadership to helping to improve population health. He was president of the UMass Memorial Accountable Care Organization, and I think has a lot of expertise from that experience and many others. So we're really looking forward to both your prior experience, David, and also your work with CVS. And finally, last but not least, Lloyd Michener, who is a family physician and emeritus professor and chair of family medicine at Duke School of Medicine. Lloyd is well known as the creator of the Practical Playbook, which is an incredible guide to help public health, primary care, and communities figure out how they might work together. And I think his perspective today will be really important. So as I said earlier, the bulk of today's webinar is not going to be presentations. We're going to have a conversation about vaccine administration and education, and then we will open it up to your questions. So let me start with Atul Gawande characterized 2020 in terms of how we were combating COVID-19 as all breakthrough, and we had tremendous breakthrough in terms of vaccine, but no follow through. So now we're 2 months in to trying to, follow through on this incredible innovation of getting these vaccines that have, such high efficacy. And we're finding that that is very, very challenging. I think in the beginning, we saw a lot of federal and state strategies really focused on leveraging hospitals and pharmacies, particularly retail pharmacies, and most recently, targeting mass vaccination sites with FEMA. And that was largely because we were focused on targeting healthcare workers, patient and long-term care facilities, and trying to get as many folks as possible immunized. Now we're at a new phase where we're still rolling through some of those populations and mass vaccination sites, but recognizing that we really need to get into the community. And it is time, maybe past time, to leverage primary care. And that is really what our conversation is about today. But all along, primary care has been involved in these efforts, even if they mostly have not been putting shots in arms. They have been answering the questions and concerns of their patients about COVID-19, but also about the vaccine. They have been combating a lot of misinformation and conspiracy theories, and really helping to triage and manage patients that, in fact, did get infected. So primary care has had a very vital role. Now I think the question is, how can primary care be better leveraged as we work together across all different sectors to try to meet our vaccine goals? So let me start by just asking our panelists to reflect on where we are with vaccine administration. Just a couple of words. How would you characterize it? And let me start with you, Darylyn.
Thank you, Anne. So I think first I just want to say this is a phenomenal accomplishment that we have such incredible vaccines that are highly, highly effective. Everyone always talks about the negative percent, but I will tell you overall, these are really phenomenal vaccines as far as vaccines go. If we take a look at the most recent data that just came out in the United States, 75 million doses have been distributed, 64 million have been administered, and at least 44 million or 17% of adults in the United States have received at least one dose of vaccine. The problem here is that we sort of have many different systems, all politics are local. And so we've seen a lot of different distribution systems, and the states have handled it all very differently. In fact, some states aren't even allowing primary care physicians to vaccinate yet. So I think that we need a more standardized, equitable approach. I think one of the phenomenon that we've seen here is that the states that have the largest wealth gaps are also the ones that have the highest inequities in distribution of the vaccine. And the folks who have underlying medical conditions, people of color, are less likely to receive vaccines to date in many of the efforts.
Thank you. That was, you covered a lot of ground. So, Darylyn, how would you characterize overall where we're at in a couple of words?
Okay, definitely could be better, and could be learning best practices and learning from each other. And I think that all hands on deck. Get your sleeves rolled up. We need to get as much vaccine into arms as possible, and we need to be equitable about it.
Thank you. Okay, To you, Lloyd.
I have to find the right button, which is a metaphor for this whole discussion, actually, is finding the buttons we need to push to get the work done. I would say we'd had a good and bumpy start, beginning with those who are willing, eager, and able. So we've had a good reach out to those, and we've been able to get it up, and just marvelously, and that the hard work is actually ahead, because we're increasingly going to be working with and to try to vaccinate those for whom trust is an issue, and for whom location, transportation, and other issues are a challenge. So I think the role of primary care is actually, could have been earlier, but it's really up ahead, where we need people who are in the communities, trusted by the communities, who can be key messengers and agents in getting this work done.
Thank you. Okay, Angelica.
Oh, I was sitting here and I was thinking, I agree with everyone that everything that's been said prior to now. I would describe it as beautiful and chaotic all at the same time. We are in a position where, you know, the transfer of power has happened and now they're cleaning up a big mess that was left behind. And as you mentioned before, state and local leaders were really at the helm as it relates to COVID-19 response, and now to try to roll out some national efforts. It's beautiful and chaotic. And I think when it comes to vaccine distribution, continuing to think outside of the box and remembering and expanding who needs to be at that table to make it happen and make sure it's equitable is essential to what we're trying to do, and, you know, to address the curve.
Thank you. David.
Yeah, thank you. I love the beautiful and chaotic. I think that sort of captures it very nicely. The words that came to mind for me, you know, firstly, historic, you know, just sort of stemming off of what Darylyn said about the incredible success in the development of this vaccine in a short period of time. And also, as we think about the public health effort here to get a vaccine out to the country in such a short period of time will be, you know, nothing short of a public health historic event. But it is, it's the other word I would say is frustrating, and it's frustrating both to patients who are ready to get the vaccine and they can't get it, and also frustrating to, you know, some providers. You know, the fact that every state has their own plan, and in some cases, the states have delegated it down to the counties. And so, you know, and again, coming from the CVS health perspective, where we are, you know, a vaccinator in many states, we will sometimes say, well, there may be 50 states, but there are 1,000 plans. And so there's a level of frustration both on the provider and the patient side. And then I guess, lastly, having been to sites where patients are receiving their vaccine, just the sense of gratitude amongst patients who are able to get it, who, you know, meet the criteria. What a sense of relief and gratitude. And so I think our job as, you know, primary care is to think about how to activate those patients who haven't gotten their vaccine yet and make it possible for them.
Well, I think each of you lifted up things that were incredibly inspiring, everything from, you know, this work that was done in a very rapid cycle to get these vaccines to market, and how efficacious they are, and also just when patients are actually getting the vaccine, but also a whole lot of disparities, inequities, chaos, and you know, trying to bring some standardization and some rationalization to the process. And there's a lot of actors, you know, that are in the kitchen, lots of chefs in the kitchen, and clearly there will need to be much more coordination and communication, you know, for us to really get to goal. You each mentioned the role of primary care, and I know I kicked off with that. And of course, as the primary care collaborative, we're going to be very focused on primary care. But I'd really like to hear from each of you, you know, what does primary care uniquely bring to the table? Recognizing that it will take many, many sectors to get us to the 75 or 85% herd immunity that we will need. Let's mix it up. Angelica, let's start with you.
So it's so interesting that the timing of this. So I went to see my primary care provider the other day, and they give you access to COVID testing in his office. I don't have to go to a specialized place or space. And I kept asking the question, do you think that you'll eventually be able to provide vaccinations, and how do you feel about that, and what would that look like for you? And he sat there and he talked to me about some of the experiences that he's had with other patients, and having to discuss everything that was mentioned before, educate them on what it means to get vaccinated, and what is accurate and inaccurate. And I think the place for primary care physicians and providers is just being the trusted voice for members of the community, this trusted resource for members of the community when they want to get some reliable information. For the longest, it's so hard to find a doctor who really and truly understands your health issues. You can stay with them for years. I've been with my doctor for 10 years. So if he tells me something, I'm going to listen to him. And he's a trusted voice for me. And so that is, and access as well. It's a place where you can go to, the location, how to get there, you understand the safety protocols that are in place. So for me, they are the trusted voices and reliable sources for education and vaccine distribution.
Thank you. Lloyd, would you like to add to that?
Yeah, I really think Angelica hit the trust, the access. And we're used to doing this. We have the ability. But I would add another, and it was in her comments, which is we're used to tailoring our communications to the individual, to the family, to the community. So this was a discussion we were having with CDC earlier today, which is one size doesn't fit all. And we need to do messaging out and through every source we can get. But ultimately, it's an individual discussion and decision. And what primary care can do is really have that discussion with people so they think it through. Because for many folks, especially in our Black and brown communities, this is not a straightforward, simple decision. This is complicated, and it needs a trusted advisor to help them think through what they choose to do.
One thing I would add to that is part of what we've done with BWHI is release a COVID-19 survival plan. It can be downloaded on our website, but it really highlights and answers a lot of the questions that members of our community have. And it's a resource that we're sharing across the board with providers, policymakers, researchers, so on and so forth. I think that being able to be informed to make that decision, and providers understanding the complexities of how Black and brown people are making the decision when it comes to getting vaccinated is so essential to being successful at what we want to do for the country.
And if I can.
Yeah, go ahead, David. Go ahead.
Sorry, I'm going out of turn. Sorry, Daryl. One of the pieces of research that CBS did that I think just speaks directly to this is a survey of around 5,000 patients to see who were the influencers around whether or not they would get the vaccine. And messages from the CDC were important. Messages from Anthony Fauci himself were even more important. But who was, head and shoulders the most important person in an individual's decision to get vaccinated? It was the primary care provider, the highest. And the other element that was interesting is that this cut across all different racial and ethnic backgrounds. And so really sort of a striking finding that underscores what Lloyd and Angelica were mentioning.
I think we've seen that. Thank you, David. And I think we've also seen that in Kaiser Family Foundation survey that the most trusted person to give you information or to vaccinate you is your personal provider or, physician or
Yeah,
clinician.
and that's absolutely true. All the surveys that are out there say that patients trust their primary care practitioner the most. And it's a person who has that longitudinal relationship and knows how to meet people where they are, understands what hesitations they might have and can address them in a real personal way rather than a paternalistic way. And I think that's really critical here. And I think that primary care also helps to overcome many of the obstacles that our patients are facing right now, the obstacles of lack of transportation to vaccine sites when they're set up at football stadiums and other places. The literacy level issue in terms of overall literacy, health literacy, let alone digital literacy, and the issues around access to broadband, and the fact that people who are essential workers and are caring for others can't spend all day trying to get on various websites to get into the queue for the vaccine. So I think that's absolutely right. And the bonus is when you go to your primary care practitioner, you can get your care also. In addition to getting your vaccine, you get a 2-for-1, a 3-for-1. So I think that that's another critical piece to this.
So, Darylyn, you mentioned trust, and I think maybe Angelica did too, and David, you did as well. So let's unpack that for a moment. I mean, what is it that is so untrustworthy about vaccines, and why is trust so important in terms of our ability to reach our vaccine goals? Who'd like to tackle that one?
I will. Behind me sits 3 very incredible people that I admire between James Baldwin, John Lewis, and Stacey Abrams, people who really focused on equity and addressing the other pandemic that has been happening for decades in this country. And because of that, we're in a situation where we're having to, as public health professionals, healthcare professionals, we're having to address the long-standing issues around racism and discrimination that has impacted communities of color. We're focusing on disparities as it relates to gender. It's so many layers to what's happening in our country right now. And when you have someone who can not necessarily and completely understand, but empathize and be knowledgeable about your experience and how the systems that you live in are impacting your overall health, that can establish a certain level of trust and open up the door as it relates to medical care. And so one of the experiences that I've had in the past, like I was trained in Morehouse School of Medicine in the Centers for Disease Control and Prevention. The equity leadership that I had there, working with Dr. Satcher, working with all of these other leaders around racism, discrimination to promote equity in healthcare, because I was trained in that, I'm able to do this level of work. But there are a lot of providers who have not received that training, or they may not be up to date on that research. So that could create some of the barriers. So trust right now, especially for those who are being, have experienced the greatest disparity as it relates to COVID-19 care, it can make or break what we're trying to do across the country.
Lloyd, you're nodding a lot. Maybe you want to jump in. And please don't be shy, guys.
I'm usually not, but I couldn't say it better than Angelica did, but I would add to it, which is that it's not that we assume trust in primary care. We really work hard at it, and training helps, and practice helps even more. But with COVID hitting and the deep roots, I call it a syndemic. It's not just an epidemic. It has roots in all the chronic diseases, the higher rates, all the housing, transportation, education issues that our communities have had to deal with. I think there's a responsibility that comes with having that trust, which is to provide the care as we do in our offices, but it's also in this time of need to go outside the office setting as members of our community and to partner to be with the community, and that could be at community meetings, it could be at church meetings, it could be at the Hispanic self-help groups, as we've been doing in North Carolina. But it's to be present and to answer questions and to help at this moment of need to heal some of those historic wounds that go back centuries. So I think we have critical roles in our offices, but I also think we have critical roles to help with our communities as trusted members when that's true.
Thank you for that. Do you want to say any more about what's going on in North Carolina?
Sure, and actually North Carolina is a good example of, I think, a positive development, because we of course had a very strong primary care association going back decades. But also we've had a strong association with the state public health department. We work, and our primary care groups are working with our local health departments. We have 80 some of those. So our primary care network health departments have been key elements of rolling out the strategy for the state. Now, let me first start with a negative story and then the positive sequelae, which is the state, like most states, started off with, we're going to message everybody and we're going to offer vaccines in central sites, and it became very clear that those sites that were being offered were in mostly white communities, and that initially the data on vaccination wasn't actually showed there was mostly going to white folks like me. So as that became apparent, it was actually the primary care groups working with the communities that pointed it out, and the state, to its enormous credit, pivoted to actually work with the primary care groups and the community partners in the health departments to start vaccinating in those communities and with the community partners as members. So we've seen our vaccination rates in our minority communities soar as that has happened. And the last bit I'd add, it's not just about vaccination. Those same sites have been offering food, access to housing, access to transportation. It's been a coordinated effort led by the communities telling us what they need. But in just about every setting, the primary care groups have been key members of those effective community collaboratives.
In Pennsylvania, and specifically in Philadelphia, we've seen some good developments. We know that one of the sites that's being stood up in conjunction with FEMA is actually at the convention center in downtown Philadelphia, which is the hub where all the mass transportation meets, the subway, the rails, the buses, so that's a really good development. And Dr. Alice Stanford, who runs the Black Physicians Fighting COVID group, they hosted a vaccination marathon at the Leah Core Center on the Temple University campus in North Philadelphia that ran last weekend. And they were able to vaccinate a lot of folks in a short period of time. So we're really seeing these best practices start to pop up, and people really recognizing and pushing the need to make sure the most at-risk folks are the ones that are prioritized in getting vaccinated first.
So, Lloyd, thank you, Darylyn. Great to hear that there are these success stories, because I think often what we read in the news is everything that's going south. And I think we have to dig a little deeper to find the good news, and to understand where there are exemplary cases, and to lift those up and to share them and to see what we can learn from communities that are doing it right. And what I'm hearing is, thinking carefully about how do you work with community groups, and asking community groups what they need to inform your strategy. Others who may have exemplar models to put on the table, or ways in which different sectors are coordinating and cooperating to try to get us to goal.
Well, and I can chime in. I hesitate to use the word exemplar, but the other part of the sort of primary care network, if you will, in a community is often the pharmacy. So the pharmacists are among, up there with primary care physicians as trusted members of the medical community. And, for one of the reasons that CVS, the pharmacy chain, is one of the partners for the federal government in terms of the vaccine partnership program is that we've got a pretty large footprint where about 86% of the United States is within 10 miles of a pharmacy. And so as we think about respected members of the community being pharmacists, we've got a population that could be very helpful. So the way we've been thinking of it, and almost half of our, interestingly, almost half of our pharmacists and pharm techs are self-identify as non-white, so of a minority community. And so one of the things that we're planning on is to have messages going out from pharmacists to patients in their community and over-indexing on communities of color to try to encourage people to come in for the vaccine. And the other way in which CVS is thinking about, we're local in terms of our pharmacy, but we're setting up partnerships with the YMCA, for example, and other church groups to partner with institutions and organizations that have a lot of credibility in those vulnerable communities, so that we can be helpful and provide information to them to then give to people in the community. And then lastly, to go that last mile, we're planning to invest in mobile clinics, vans, community clinics to try to get that get the vaccine to people where they are. And I think one of the strategies that we'll have to do is sort of over-index to make sure that we're trying very hard to target these Black and brown communities. And I think that's going to be really should pay off dividends in the end.
As David was talking, oh, I apologize. As David was talking, I was thinking about what was happening within the city of Atlanta and how we had primary care providers who would reach out directly to the mayor's office to figure out how they could support what we were doing at a city level. And it was the primary care providers and leaders of local clinics and some of our hospitals. We connected with them to ensure that our messaging was correct to inform mass communication across the city. It was a great opportunity to also, we worked with a couple of folks from CVS to really highlight some of the messaging around where to get access to testing. And I know that they're doing the same thing as it relates to vaccines, as along with the plan that's rolling out at the state level. We partnered with the Fulton County Board of Health to roll out 90% of our initiatives as it relates to COVID-19. And now Fulton County Board of Health is working with the state to open up the convention centers so people can get access to vaccinations. And so some of the people who weren't partnering before COVID are working together now to really ramp up that response. And I just remember how we had so many physicians reach out to us directly to say, I have the training, I have the team, and I want to be able to provide those services. So I would also say, don't underestimate the access and the resources you can provide to local policy and even state leaders. So yeah.
Could I pile on?
Yeah, go ahead, Lloyd.
I think what we're seeing and what we're describing is something that we all were working on before COVID hit, which is really about the partnerships, and that we could call it advanced medical homes, medical neighborhoods, but it's really about how do we strengthen the ties between primary care and the communities. And then COVID has accelerated those partnerships. The groups that we hadn't successfully partnered with, we're starting to, and those that we already had partnerships, those are strengthened. And I think it really offers the opportunity to, one, show what we can do, which isn't always first of mind, as we've seen with some of our policy leaders, but also to create a structure that responds to COVID and then can continue as we work with our communities about all the underlying issues that have caused those disparities in the first place, and which COVID just exacerbated, seriously.
Yeah, I think that's exactly right. You know, there are some silver linings here, and the amount of communication, collaboration, coordination that we're starting to see take place is critical. We need to ensure that that is seamless, it's integrated, and it's sustainable, so we don't lapse back after this, because we know that our information systems are not interconnected in the way that they need to be to serve the patients and the public health of communities. So I think there's a lot we can learn from this. I do think, and I do worry about primary care. You know, primary care going into COVID was really at risk. You know, the sort of the primary care investment, and knowing that, you know, a lot of care is given in the primary care setting, yet a lot is not invested. And you know, many practices are, you know, open until 4 or 5 p.m. just to keep the lights on, and they're doing it for good reasons. We've seen so many folks in the primary care realm take no salary or cut back significantly on their own salaries so that they could keep their practices going through this. And so I think we need to understand that primary care, which sounds simple, is anything but simple care. It's the most complex care you can possibly do, and it's the foundation and the backbone for care in the United States. And we have to figure out how we're going to be able to not only get it to survive, but now thrive through COVID and beyond.
Thank you, Darylyn. I often think of primary care as incredibly vulnerable, and COVID-19 has made it more so, but also I think the pandemic has also underscored how valuable it is, because we know that patients who have, you know, comorbidities are more at risk. And we've also seen how all of this has exacerbated health inequities. And we know we can do better in this country in terms of health promotion and chronic care management and the like. And we certainly don't want to be going down the road we're on now in terms of you know, our health outcomes. We've got, why don't we turn now to education? You know, clearly there are many in our communities that have concerns and questions, and even have been very clear that they're not interested in getting the vaccine. You know, there's lots of work to do to turn that around. Some of you may have experienced this in your own work. I mean, David, you know, CVS was going in and administering vaccines in long-term care facilities, and yet a high proportion of workers in those facilities were opting out. Maybe you find that also true in CVS clinics, that folks are opting out of getting the vaccine. And I think, you know, Darylyn and Lloyd, you may have encountered this as well. We know in primary care offices, some people are not getting the vaccine, and that's true in hospitals. So, you know, what have we learned thus far about how to address people's questions and concerns, and even, you know, to work towards overcoming hesitancy, either your own personal experience with doing this with friends, families, or in your day jobs, and then we can talk about what we know from some of the evidence from the pediatric world that's been dealing with vaccine hesitancy for some time. Let me kick that off. Who'd like to take that question first?
Well, I mean, I think it's again goes to sort of meeting people where they are, understanding what their concerns are in a real human way, and addressing them. And you may not have you know, a successful conversation the first time, but it's staying in the game, right? It's the long game, and staying in that conversation. And I think that as we see more and more critical mass of people getting vaccinated, people recognizing that it is the responsibility to their loved ones and to the people around them to do this, that we will, I think, start to overcome that. But it's the same thing that Atul Gawande said, you know, that primary care is the heroism of incrementalism. It's, it's incremental and it's longitudinal, and we shouldn't be discouraged. I know that many of my colleagues have had folks that they work with who initially were hesitant, and they stayed in those conversations and they made it real and personal. And, they were able to win over minds one person at a time.
Thank you.
The thing I would add, if I could, to Darlene's great summary, is to not assume the problem is ignorance. Sometimes it is, sometimes it's misinformation, and sometimes it's just a different view of the world. I mean, remember, we had the anti-vaxxers before we had COVID. I haven't heard from them in a while, but there are folks who just don't think the way, don't put the same value on science as we do. So the part of the incrementalism is understanding the perspective of the people, the groups that we're working with, and responding from where they are. And I think Darlene put it right perfectly. But this is why I have concerns about mass marketing of the message of we have the scientific answer. We do. I mean, that's true of all science. There's some small caveats with that. But not everybody believes the science, and not everybody believes science. So framing, and I think this is going to be the hardest part of the journey, is working with people whose values and the use of language and framing is fundamentally different than ours. I would add, by the way, there's a real excellent effort of the Bowman Foundation, CDC Foundation, around messaging and framing, so that we use language effectively in working with people whose backgrounds are different than ours. We're used to doing that at Ed.
David, looked like you wanted to jump in.
Yeah, just to add on a little bit. I mean, and I think the comments are right on. In the end, it's it's an individual conversation in the right language from somebody if they trust the message. And so for us, I think then the next question is, how do we get that information to people to have those conversations? So, it's not going to be me having that conversation. It's going to be somebody in a church group or in a YMCA. And so, to Lloyd's point, there are a lot of different pieces of misinformation or other concerns. And part of our goal, I think, is going to have to be to educate the educators, train the trainer kind of model, so that those conversations can occur.
One thing that I really have enjoyed, and I got to talk about this a little bit right at the beginning or the middle of the pandemic. Anytime something like this happens, we see a lot of innovation across the board, whether it's education, art, health, public health, technology. We have found multiple ways to use what we've had before and create new ways to communicate and educate people. And I really like the fact that people are using things like Instagram, Twitter, other social media platforms to connect with people that they wouldn't normally be able to connect with or communicate with. One thing that I kept thinking about when we were putting out messages to tell people what to do if you have certain symptoms, we would tell people to talk to your primary care provider or talk to your primary care professional. But the thing that kept crossing my mind is, what if you don't have one? Or what if you don't know what that is? Or what if you don't know where to go? Or what if you don't know that you could go to a Minute Clinic and talk to someone? You see what I'm saying? There's this huge gap when we have these conversations and we put certain recommendations out there, and be able to communicate the basics of what people need to know so they can have a strong foundation. And using technology and all of this innovative resources that we have out there to spread that message is so important. The other thing that I really like to talk about was just getting back to the basics and knocking on doors. I think that we forget that boots on the ground is part of the foundation for public health and healthcare. And so that is a part of what we did through the city. We used text messaging, we did cold calls, we left messages. We also, updated our social media platforms, and then we went out and knocked on doors as well. So we have to get back to the basics as well as use the innovative technology that we have available to us.
Think globally, act locally, right?
Yes, exactly.
And I'm guessing the we who is knocking on doors wasn't just doctors, but it's actually the whole team, but it's the broader team. I mean, so it's public health workers, community health workers, um, members of the faith community. I'd add in North Carolina, dentists actually are part of the another of the some trusted folks, but they now can deliver vaccines, administer vaccines, and working with some of the rural areas. Agricultural extension agents are way up there as stress agents, so they can be effective messengers too.
So what I'm hearing is there's going to take a lot, we need a lot of modalities. We need very targeted messages depending upon what community you're trying to reach. And the messenger needs to be trusted in that community. And so there's a lot of customization. Is there any room for, a national campaign? Certainly that's being discussed at the federal level, in terms of mass communication around vaccines. I mean, is there a role for that, or does it really need to be so customized?
It's both and I think the Ad Council and CDC and others are working on that mass campaign, and it'll come out through multiple venues. But the point here is that that's probably necessary, but not sufficient.
A lot of the message is gonna be to go talk to your physician, your primary care practitioner, professional, or other person that has healthcare professional experience in your world.
Right, and then it comes back to that trust. Who do you trust to talk to about something that is so intimate and something that you're very fearful of? And I think there's also a whole psychological dimension here. I think we put up in the tools a resource that just came out from the American Psychological Association, a toolkit about how to address vaccine hesitancy from that standpoint, thinking about the psychological issue that may be also impacting people's hesitancy. Okay, well, we're going to turn to some questions that have come up through the chat, and I also invite all of you, if you think there's a topic that we haven't yet had a chance to really drill into, to talk about it. One question is about primary care's ability to target populations. Can you say more about that? Because when we start to think about certain populations that we're not yet reaching, what tools does primary care have at their disposal to try to get to patients and bring them in to get vaccinated? Lloyd, you had a big smile.
Oh, I want to go for that one. Oh yeah, it's a wonderful question, and the answer is we have two sets of tools. One is our own data, and if you're in a practice that actually can analyze your data, especially around race and ethnicity risk factors, and geoanalyze it, and a number of practices do have that, then you know where to go. You know where to reach out to, and even somewhat which groups to partner with. If you don't, and many practices don't, CDC has been doing some beautiful work, which is accelerating on getting at least the zip code level analysis, not county, the zip code. And if you go to CDC places, you can actually see much of it is predicted. They'll actually show you the zip code level analyses of which places are most at risk and most vulnerable. So you can really use that to target. And I think that ability to target the outreach, one, is really respectful of our limited resources, also make sure we're effective, but it also works not just for COVID. This is a really cool toolkit for us to keep as we deal with diabetes and hypertension and low birth weight and maternal outcomes. So this ability to use data at the hyper-local level very precisely, I think needs to be part of the primary care toolkit in the now and in the future.
Terrific. One fact from the Green Center survey that just came out this week of over 900 primary care clinicians across the country, that over 60% of them have created eligibility groups and have started to do proactive outreach campaigns to their patients. So even without maybe the sophisticated tools that you've mentioned, Lloyd, I think primary care has taken it upon themselves to say, okay, we know we've got these vulnerable patients. How can we reach them?
And could I take it one more step? And this may be news to many of the folks on the call, but it actually comes out of the administration's efforts around health equity and the work that has been done earlier on disasters in communities. But it comes out of disaster response teams because they're used to gathering data and analyzing it. So oh, come on, I can't think of the name, Homeland Security Group and working with FEMA has a data set called Medical Public Health Information Sharing Environment. And any primary care provider can get access to that, which actually provides very concrete, specific data on what's going on in their community. And even better, you can use that, turn that into targeted outreach and communication tools for your practice with your community. So there's a national movement under HHS to actually look at how do you make those tools which come out disaster recovery available to the healthcare setting and to those communities at the same time.
Terrific. Another question, and I think this is focused on you, Lloyd, but Angelica and David and Daryl, you may want to jump in here as well. The person asked, why is primary care not more integrated with my local health department? I think they're lamenting the fact they're disconnected. And I've got a data point on that, which, only about a third of primary care has this strong connection to public health from a recent Green Center survey. So who would like to take that question, and also how do we fix that disconnect?
So I'll do a first crack, but then I'll quickly, because this is something I've been plugging on for a few decades. The short answer is that everybody's busy, and if primary care has been underfunded, public health has been even more so. I mean, just the loss of funding, the loss of the workforce in public health has just been staggering. I'm not going to try and quote those numbers because I'll get it wrong, other than it makes us, and to many public health groups, primary care actually looks like the wealthy cousin, a family member, and that's truth to that. So part of it's just that they got too much work and not enough time to do it, something which we can feel some sense of family resemblance to. So that's part. The other is we actually come from different training backgrounds and experiences, and we haven't until recently started to work together. But that said, and it goes to that Larry Green Center, we started to, it actually goes back closer to 20 years about partnerships and growing, because we actually complement each other's work and we're each more effective when we have those partnerships. And the last bit, and I'll be quiet, is that this idea of supporting these partnerships, primary care public health, is actually, I think, part of what you can read in the executive orders that are out there about looking how we weave the federal, state programs around the needs of our community so that people have the opportunity not just to be healthy, but to thrive.
Yeah, I mean, I think the lessons that we're learning is that when you've seen one community, you've seen one community. When you've seen one practice, you've seen one practice. And we really need to be able to learn from this and be able to move forward. You know, we're seeing that there is a lot of care of acute diseases that have not been diagnosed, chronic diseases that haven't gotten the attention that they've needed in our patients, and of course the acute issues around mental health and what has happened with the pandemic. We're going to, at the end of this, we're going to say, wow, we got through it, but there's going to be a lot to be done, and that in terms of care for our patients, and there's going to be a lot we need to learn and lessons learned to move forward so that we don't deal with the next pandemic the way that we're dealing with this one.
I just want to add that I am so grateful, and I think this was mentioned a couple of times. We need to invest in our health system across the board and public health as well. Just the investment so that, and I love the word sustaining, making it sustainable so we can have some long-term progress. That investment is essential, and I feel like every platform I get on, I have to make sure I say that we need to invest in these health systems that we're working in.
If I could pile on one more. I know we're getting close to time. And I'll be brief.
I'm sorry, Yeah, go
I was
ahead.
going to pile on just briefly and say, I think what's going on here, which is really important and will serve primary care well, is a move from focusing on healthcare to focusing on health of people, especially in our health for everybody, and really around thriving and weaving together all these themes. I think primary care, we've tended to see our affiliations, allegiances, alliances with the bigger healthcare system and our hospitals, and those are really important. But I think perhaps we've forgotten that the other part of the bridge, which is to the community. And I think what we have the opportunity now is to really build those systems for resilient communities in ways that are sustaining and economically successful for everyone.
Mhm.
Amen to that. On the investment front, we've more recently been looking at primary care investment levels, both at the national level and at the state level. And other countries have been doing this for some time. And it really has been startling to see what the low investment is in primary care. A study that we put out at the end of last year showed that actually it's been declining as a percentage of total cost of care. And I think that is true, and maybe even more so in public health. So it's perhaps not a surprise that we haven't done so well with this pandemic. And clearly, if there's one lesson coming out of this, I hope it's that we need to be investing differently to get different outcomes for the patient population. So I think that's a key takeaway message. We've got just a couple of minutes, and I'd really like to do a round robin and just offer you each an opportunity to, your last word of advice if you were sitting down with President Biden and he asked you, what is the most important thing the administration can do, to get it right in terms of the COVID-19 vaccine. So give you a moment to think about that, and just remind everybody who has tuned in, and thank you so much for joining us today, that this broadcast will be available in 48 hours. So this will be real quick. We've just got a couple of minutes. So Angelica, I'm going to start with you. What's your message?
Trust is everything. Trust and communication is essential to the success of what you want to do across the country. That is what I would share. Reestablishing that trust, communicating and integrating the plan across the board. That's what we need.
Thank you. David.
Yeah, I think a combination of central control, so federal control to push things out, but really the end game is local empowerment. So I think that is a key piece of how we're going to be effective.
Great. Sherilyn.
So I talked about, what a fabulous vaccine the COVID-19 vaccines are, but there is no vaccine for racism. And we need to be able to address the health inequities that we're seeing with the vaccine and be able to take those principles and push them out and generalize them to the entire healthcare landscape. We're all stronger together, and we need to have those lessons learned and be able to move forward.
Thank you. Excellent. Lloyd, you've got the last word.
Okay, and I'm going to actually use some of President Biden's words in answering the question, which is support our communities and those who serve them so that all can be healthy, all can thrive, and so all our communities can be prosperous.
Absolutely.
Okay, on that note, thank you all so much for joining us today, and please thank our wonderful speakers. Really appreciate your time and your passion and your commitment to this charge we have ahead of us to vaccinate Americans.
Thank you.
Thank you.
Bye.